Super. So thank you very much, Karen. So welcome to our brand new cerebral blood flow virtual seminar series. So we are very excited to have you here. The first day has finally come. So you may have seen on social media and here, we already have 13 confirmed seminars until the end of 2020. So it was an amazing response from our community, and we would like to, Caroline and I would like to thank you very much for contributing to these upcoming seminars. This COVID, I'm not the only one, this COVID situation clearly led to missed opportunities for students to present their work. So we had this in mind when organizing this series. So this is why for every seminar presented, that we will have like one key speaker and 4 abstract talks given by grad students. So we really hope that you will enjoy that series, and I think we found like the best in the world to present. So I think there is not a lot of meeting that could offer that kind of science. So that would be very exciting. So maybe just some basic rules of engagement during the seminars. So please, as we said a little bit earlier, keep your microphone on mute and video off throughout the session. That will definitely facilitate the exchange. There will be like a 5-minute question and answer period for the keynote speaker and 3 minutes for abstract talks at the end of each presentation. So we will ask you to send your question via the chat feature and not by demuting you. So just send us the question by chat, and we will, if we have time, we'll ask the question to the speakers. And for those who won't be able to attend, each session will be recorded and posted on the CARNET website within the week. So we'll have, and even for those who want to watch again, so we'll have access to it. So again, for Caroline and I, thank you for your support in terms of answer from the community. And without any further delay, let's start off our first seminar entitled Cerebral Blood Flow Regulation During Hemorrhage. And the chair of this session is the co-organizer of the series, Dr. Caroline Rickards from the University of North Texas Science Center. Caroline?
Thanks so much, Pat. Thank you for that introduction, and also thank you for your enthusiasm and motivation to get this seminar series up and running. It really is amazing how fast we're able to get really great keynote speakers and abstract talks together. So I look forward to the next 6 months of seminars on cerebrovascular physiology. So I'm really excited to be the first keynote speaker for today, really focusing on a lot of the work I've been involved in for the last few years, assessing cerebral blood flow responses during hemorrhage. So just in terms of hemorrhage etiology, I'm describing here that hemorrhage, not so much cerebral hemorrhage, but more conditions where you'll lose a large amount of blood volume, which will then limit the amount of blood that can get to the brain. And cause hypoperfusion and hypoxia at the level of the brain. So some of the causes of this type of hemorrhage could be trauma, could be complications of childbirth or surgery, could be ruptured ulcers. And the first time in my scientific career, I'm able to present a picture from Downton Abbey. Those who are fans may remember Robert, who actually had a ruptured ulcer, which caused a lot of blood loss. Clotting disorders such as haemophilia, hemorrhagic diseases, including dengue, fever, and Ebola. And traumatic hemorrhage is really a severe condition that is the leading cause of traumatic death in both the civilian and military settings. And it's also responsible for about 80% of potentially survivable battlefield injuries. So hemorrhage can be classified into 4 different classes, and that they are dependent upon the volume of blood lost. And so you can see here we have class 1 through to class 4, and class 1 is about 750 mils of blood lost, which is approximately 15% of total blood volume for an individual who has about 5 liters of blood volume in total. And then moving along here to 2,000 mils of blood lost, which is about 40% of total blood volume. And throughout the course of blood loss, you'll see that blood pressure, while relatively well maintained in these initial stages, will progressively decrease as you progress through the blood loss injury. And you also then get a compensatory increase in heart rate as you lose more blood volume. You get an increase in respiratory drive, so increases in respiratory rate and respiratory volume. You can see going from 14 to 20 breaths per minute, all the way up to 35 breaths per minute. And then mental status, based on reductions in brain blood flow particularly, will change from someone who might be slightly anxious with this low level of blood loss all the way through to a loss of consciousness. And what you can observe with this table here, which is a classic table that's presented in many clinical textbooks, and this one is actually from pre-hospital trauma life support. There's no measurement or indicator of the responses of cerebral blood flow, and that's because it's a really difficult thing to measure in the clinical setting. And so I've actually just added this in to put this in context in terms of what's happening to brain blood flow, really on a theoretical level, because it's so difficult to measure in humans during actual blood loss. So you can see that in these first couple of classes, cerebral blood flow will be relatively well maintained, mainly due to the autoregulatory response, ensuring that brain blood flow is preserved. But then there'll be progressive reductions in brain blood flow as blood pressure starts to fall, as subjects start to hyperventilate, so we get a reduction in arterial PCO2, and eventually you'll get this massive reduction in brain blood flow, which is aligned with loss of consciousness. So in terms of the overall cerebral blood flow responses to hemorrhage, this is a picture from a paper back in 1991 showing kind of the theoretical responses of brain blood flow on the top panel here, oxygen extraction fraction, and the cerebral metabolic rate of oxygen on the bottom panel, as we see changes in perfusion pressure on the x-axis. So this is really a representation of what we would consider the classical cerebral autoregulatory curve, where when we move from right to left along the perfusion pressure here, we get to what is termed the lower limit of cerebral autoregulation, where we will see reductions here in cerebral blood flow. There's a compensatory response to that. We'll see increases in oxygen extraction to enable or to ensure that cerebral metabolic rate of oxygen is well maintained. However, we can reach then another critical threshold here at point B, this line here, where you get dramatic reductions in cerebral blood flow. Cerebral oxygen extraction continues to increase to try and meet metabolic demand, but it's just you're not able to extract sufficient oxygen from the reduced blood supply to the tissues. And so you then start to see decrements in the cerebral metabolic rate of oxygen here on the left-hand side. So clearly, adequate cerebral perfusion and oxygenation is essential for maintaining consciousness. Reduced blood volume that occurs via hemorrhage really challenges cerebral perfusion and the subsequent delivery of oxygen and metabolic substrates to the tissues. There is actually an increased proportion of blood volume redirected to the brain during hemorrhage. So at rest, about 12 to 15% of cardiac output is distributed to the brain, and that will progressively increase as you lose more blood volume in order to protect that vital organ. And actually, at the level of the brain itself, there's a redistribution of blood volume to specific regions that are essential for survival, such as the brainstem, where we have autonomic and respiratory control centers. So not only are you getting more blood distributed to the brain, but within the brain itself, there's regional redistribution as well. So there's a very complex interplay of factors regulating cerebral blood flow during hemorrhage. And here's just a representation of some of those factors that we should be considering when talking about the responses to hemorrhagic stress. So first of all, we have reductions in arterial pressure and reductions in cardiac output, which will challenge cerebral blood flow. So every time you see a negative symbol here, this is having a negative impact on cerebral blood flow. So obviously arterial pressure, cardiac output will decrease during blood loss injuries, which will have a negative impact on brain blood flow. Cerebral autoregulation, the traditional autoregulatory curve actually shifts to the right. And so at higher arterial pressures, you'll have a pressure passive response of cerebral blood flow. So there's less protection of cerebral blood flow due to cerebral autoregulation during hemorrhage. In terms of blood gases, I'm sure this is not a new concept to everybody who's listening in today, but the brain is very sensitive to changes in arterial partial pressure of carbon dioxide. So with the hyperventilation that's occurring during hemorrhage, you'll see a decrease in the PCO2, which will cause a vasoconstriction of the cerebral vasculature and reductions in brain blood flow. Now, I have here for PO2 that there's actually a quote-unquote positive effect. I'm not sure how positive this is, because the hypoxia that's occurring during blood loss injuries will eventually lead to an increase in brain blood flow at a specific threshold of arterial PO2. So there is a positive consequence of this reduction in PO2, but it's really because you've lost a lot of blood volume before that occurs. So it's a kind of a positive, but not really in terms of survival of the organism. Increases in sympathetic activity may cause constriction of the cerebral vasculature. Similarly, decreases in cholinergic activity may cause reductions in brain blood flow. Metabolic demand, so if you have regions of the brain that are highly metabolic, such as the brainstem, maybe centers that are responsible for the responses for psychological stress and anxiety, there might be increases in metabolic demand for that reduced blood volume as well. So that can just really challenge brain blood flow regulation and maintaining blood flow to all regions of the brain. So you might have some compromise in some regions of the vasculature. And then lastly, in this figure is intracranial pressure. And so again, this has a somewhat of a positive effect, but only because the reduction in cerebral blood flow will reduce cerebrospinal fluid production, which will decrease intracranial pressure. And obviously just the reduction in blood volume in the brain will reduce intracranial pressure, which will subsequently improve cerebral perfusion pressure. So there is some positive effect, but again, it's occurring because you've lost so much blood volume in the first place. So some of the early studies of hemorrhage in humans were really focused on many of the basic hemodynamic effects. This study from 1944 from Barcroft, published in The Lancet, was actually performed on healthy human subjects in the days where you could do all sorts of things to medical students without getting ethical approval. In this case, the subjects had about 1 to 2 units of blood withdrawn. And in this example, there was about 1,020 mils of blood withdrawn, which is about 1 to 2 units, as you can see on the left-hand side here. And so there was a number of key hemodynamic responses that were recorded. We have blood pressure, right atrial pressure, and cardiac output. And you can see that all of these responses are decreasing as the volume of blood removed is increasing. And then you'll have a compensatory response of increases in heart rate and increases in vascular resistance to compensate for that reduction in blood volume. And then at the point of faint here, so the individuals actually lost consciousness, and that's associated with this decompensatory bradycardia, vasodilation, and then obviously this massive reduction in arterial blood pressure. So you can see here that cerebral blood flow and oxygenation were not measured at this time. The modern techniques had not been developed at this point in history, and so we didn't really have a great understanding of what was happening to cerebral blood flow and oxygenation in these human subjects back in the 1940s. And also there was very limited dynamic monitoring technologies at that stage. So it was difficult to get continuous measurements without invasive measures such as intra-arterial recordings or these right atrial pressure recordings. So I think we've come a long way in terms of being able to measure what's happening at the level of the brain with our more recent technologies. So how do we assess responses to hemorrhage in humans? I know many of you are very familiar with the technique that's shown here in this picture called lower body negative pressure. And this is actually me inside our lower body negative pressure chamber in our lab just across the hallway here. And so we basically seal subjects at the waist. And so their lower body is inside this airtight chamber and the upper body is lying outside the chamber. As we apply pressure, relative negative pressure to the chamber, we're moving blood volume from the upper body into the lower body, so away from the heart and away from the head. And a protocol that we often use in our lab, and has been used for many decades now, is this stepwise protocol, where we can progressively decrease the chamber pressure over, in this case, 5-minute steps. And you're moving more and more blood volume from the upper body down into the lower body. And that will subsequently reduce your venous return, reduce your stroke volume progressively, as you can see in this bottom panel here. And we actually see about a 50% reduction in stroke volume when we take our subjects to a point of pre-syncope. And in our lab, that's defined as a systolic arterial pressure less than 80 millimeters of mercury, and symptoms of lightheadedness, nausea, dizziness, and blurred vision. And those symptoms are coincident with these reductions in cerebral blood flow. And this is indexed here by middle cerebral artery velocity. You can see that MCA velocity is progressively falling throughout the LBMP protocol. And we see about a 30% reduction in MCA velocity from baseline to pre-syncope in our subjects. So for many decades, the lower body negative pressure protocols were being used as a method of simulating hemorrhage, but we didn't have experimental evidence to demonstrate that there was a close matching of the responses to LBMP and actual blood loss. And that was up until a few years ago, where there were 2 studies that were conducted in parallel, one in baboons and one in humans. And I think Carmen actually is on the call. I just saw her log in earlier. This study was actually run by a group at the US Army Institute for Surgical Research, where they compared the cardiovascular responses to hemorrhage and LBMP in a baboon model. So you can see the baboon here is sealed at the waist again inside this LBMP chamber. And there was a direct comparison of the cardiovascular responses to hemorrhage and LBMP. So in these animals, about 25% of their total blood volume was removed in 4 aliquots, as you can see here on the x-axis, from 6.25% up to 25%. And central venous pressure was measured throughout the protocol. So in the closed circles here, you can see the central venous pressure responses as the hemorrhage progressed from baseline through to 25%. About 2 weeks later, they brought the animals back into the lab, and they repeated the study now with the lower body negative pressure protocol. And the idea here is that they applied LBMP until the central venous pressure decreased by the same magnitude as what was observed in that animal during the hemorrhage protocol. And so for this first step here, 22 millimeters of mercury LBMP was required to elicit the same central venous pressure response as that occurred during the 6.25% hemorrhage, and all the way up to the 70 millimeters of mercury LBMP here at the 25% hemorrhage mark. So this was the design of the study, where CVPs were matched for both the protocols. And then an outcome variable, many outcome variables were measured, but I'm just representing the stroke volume response here. And you can see that there's really close matching of the stroke volume throughout the 2 protocols. So the LBMP was really clearly eliciting the same responses as the hemorrhage in terms of stroke volume response. And then these investigators went back into historical human data and actually then overlaid the human LBMP responses in terms of the % change in stroke volume on top of the baboon data from both hemorrhage and LBMP. And so you can see here that there's a progressive reduction in stroke volume in the human studies, which is matching over the baboon studies. And these investigators then quantified the volume loss and how that equated to the LBMP stage. So for example, here, a 4.4 mil per kilogram blood loss would occur at the 20 millimeter of mercury LBMP stage, all the way up to 17.8 millimeters of mercury per kilogram at the 70 millimeter of mercury LBMP stage. So this was the first study that really quantified the cardiovascular responses to both LBMP and hemorrhage in the same model. At the same time, Mike Joyner and his group, Jill Barnes, I think is also on the call today, was a lead in this study also, where they compared responses in humans. So there's not many places in the world that can do this type of study, and Mayo Clinic is certainly one of them. And in this study, the design was a little bit different. They had their human subjects come into the lab, and they participated in an LBMP protocol and a blood loss protocol on the same day in a randomized order with sufficient recovery time between. The LBMP stages was pre-selected, so they started here at baseline and then went to LBMP of 15, 30, and 45 millimeters of mercury. For the blood loss protocol, they had their measurements at baseline, and then they removed about 1,000 mils of blood from each of the subjects in 3 equal aliquots of about 333 mils. So here you can see that the central venous pressure response to LBMP on the x-axis and the central venous pressure response to blood loss on the y-axis. And you can see that there's a strong linear relationship between these two responses. However, interestingly, the LBMP actually elicited greater reductions in central venous pressure compared to the blood loss protocol. So central venous pressure started here at about 7 millimeters of mercury and decreased down to about -1. Whereas the blood loss protocol, they started with a CVP of around about 6 and it decreased to about 1. So the magnitude of reduction in CVP was less with the blood loss protocol compared to the LBMP protocol. And similarly, the stroke volume response showed the same sort of pattern here. So tight linear relationship, but the magnitude of central hypovolemia was less in the blood loss protocol compared to LBMP. Jill Barnes and I also published on the middle cerebral artery velocity responses that occurred. So I was really thankful they were able to measure brain blood flow responses during these protocols. And we compared the middle cerebral artery response to various measurements, including arterial blood pressure, central venous pressure, stroke volume, and cardiac output. And again, because the magnitude of hemodynamic stress was less with blood loss versus LBMP, you can see that, for example, the blood pressure response is smaller with blood loss compared to the LBMP, but the trajectories of these responses were very similar between the LBMP and blood loss conditions. So, the brain is responding in a similar fashion to blood loss as it does to the LBMP stress. So how is the regulation of brain blood flow related to tolerance to this simulated hemorrhage? And then how could that potentially be applied to the clinical setting where individuals are actually losing blood volume? We conducted a large study for my postdoc work where we actually had 135 healthy human subjects participate in a maximal presyncopal limited lower body negative pressure protocol. So this study was conducted over many years, as you can imagine, to get 135 healthy subjects through the protocol. We actually divided our subjects into individuals who were considered high tolerant versus low tolerant. So you can see here we had 93 high tolerant subjects in the closed circles and 42 low tolerant subjects in the open circles. And they were classified as high or low tolerant based on their ability to make it through the -60 stage of LBMP and onto higher stages or not. So 93 subjects made it through to higher levels of LBMP than 60. The low tolerant subjects terminated during the 60 stage of LBMP or at earlier stages. This is the percent change in stroke volume here. And you can see that stroke volume is progressively falling for both groups of subjects with slightly greater reductions in the low tolerant subjects. And then at presyncope, this is about the last minute prior to presyncope for all subjects, regardless of their tolerance. You can see that the high tolerant subjects were able to tolerate greater reductions in stroke volume compared with low tolerant subjects at presyncope. When we assess the arterial pressure responses, again, the high tolerant subjects with the closed circles, you can see arterial pressures are relatively well maintained up to -60. And then there's a reduction in arterial pressure for the low tolerant subjects, which is coincident with the onset of symptoms that are occurring. And there's no difference in mean arterial pressure at presyncope between these two groups. Now, importantly, oh, my light just turned off. Importantly, we have the mean middle cerebral artery velocity responses here in the high tolerant and low tolerant subjects. And you can see that there's progressive reductions in middle cerebral artery velocity in both groups with a slight protection of the velocity in the high tolerant subjects at -60. And really interesting response here at presyncope, the high tolerant subjects were actually had a lower MCA velocity at presyncope compared to low tolerant subjects. So they're able to tolerate greater reductions in both central blood volume and greater reductions in cerebral artery velocity. So that was interesting in terms of our absolute responses, but perhaps most importantly, at least for the work that I've then carried on with beyond this particular study, we actually observed there were differences in the waveforms of the cerebral blood flow and arterial pressure between individuals who are high and low tolerant. So in this example, I have one subject in the last few minutes of their LBMP protocol prior to presyncope. This is their MCA velocity tracing on the top panel. And on the bottom panel, we have a separate subject, again, in the last few minutes of their protocol. And you can see that there is a very distinct difference in the pattern of response between these two subjects. And interestingly, the subject at the top was low tolerant, only made it about 10 minutes into the protocol, versus the bottom subject was a high tolerance subject, making it about 30 minutes through the protocol. However, what was really intriguing with this is that if we were just to measure the average response, so the mean response across this time period, there would be no difference in that measurement. So we have 53 centimeters per second in the top, 54 centimeters per second in the bottom panel. So if we were just to measure the mean response, we wouldn't be able to distinguish the low tolerant from high tolerant subject. So what we actually did here was we performed a fast Fourier transform on all of our data to determine what the frequencies of these oscillations were and the amplitude of those oscillations. And we were very much focused on the low frequency band, around about 0.1 hertz, which is a 10-second cycle of oscillation, so 6 cycles per minute. That was the peak that we saw when we were analyzing these data. So when we examined that frequency band, which is classified as the low frequency band, we found some interesting results. So here we have the mean arterial pressure, low frequency power in the high tolerant versus low tolerant subjects. And you can see at the -60 stage of LBMP, the high tolerant subjects are exhibiting this increase in low frequency power of arterial pressure compared to the low tolerant subjects. And then at presyncope, there was greater low frequency power again in the high tolerant subjects compared to low tolerant subjects. And we saw this again in the middle cerebral artery velocity recordings as well. So we saw this increase in the mean arterial pressure LF power and the MCAV LF power at the -60 stage of LBMP. And we saw this again at the presyncopal level as well, where there's higher power in MCAV, low frequency, compared with the low tolerant subjects here. So this was kind of the first glimpse of an interesting finding that was associating increased oscillatory characteristics of blood pressure and cerebral blood velocity in high tolerant subjects. And these were spontaneously derived oscillations in these hemodynamic responses. So some work that we've now continued on in my lab here at the North Texas Health Science Center, and really the focus of Garen Anderson's PhD project, and he'll be presenting more on this in the next talk, we're actually developing what we call a pulsatile perfusion therapy. And what we can actually do is force the oscillations in hemodynamic responses at specific frequencies. So we use, again, the lower body negative pressure protocol, and we can actually oscillate the pressure inside the chamber, which will then induce these oscillations in arterial pressure and cerebral blood flow. So here in this protocol, you can see we can reduce the pressure in the chamber to -60, and then we can oscillate the chamber pressure at 0.1 hertz, 5 seconds at -30, 5 seconds at -90, and continue these oscillations for about 10 minutes. We also examined oscillations at 0.05 hertz, and at a slightly slower frequency, so 10 seconds at each of the pressures. And we compared that to the control condition, where we just have a reduction in chamber pressure to -60 and keep it static at that state, at that level of LBMP. So this is our 0 hertz profile. So this is just this next slide shows you what's occurring in terms of the hemodynamic responses. So on the bottom panels here, we have the chamber pressure, so 0 hertz, 0.1 hertz, and 0.05 hertz. And we can see the oscillations in arterial pressure here are occurring at those frequencies of the chamber oscillation. So 0.1 hertz, nice robust oscillations in mean arterial pressure. And then at 0.05 hertz, you can see the slower oscillations. So I'm not going to spoil Garen's story. So Garen actually will talk more about his findings in his presentation that's next. And he'll just describe some of the responses of cerebral blood flow and cerebral oxygenation with this pulsatile perfusion therapy treatment. All right, so let's just move on and talk about the responses of oxygen extraction and how that can compensate for decreases in cerebral blood flow. Just reflecting back on one of the first slides I presented this morning. So this is actually a table of data back from 1961, where a number of individuals who are they're on the older side, about 62 on average. We had 8 individuals who were transitioned from a supine position to head-up tilt, and their cerebral blood flow and cerebral oxygen delivery and arteriovenous oxygenation were assessed. So here on the left-hand side, we have cerebral blood flow at rest is the C condition, and E is during head-up tilt. And all the subjects were taken to pre-syncope, and some were actually taken to syncope, so they actually fainted. And so they're the 2 conditions we have here. And on the bottom are the mean values. So cerebral blood flow decreased by almost 50%, as you can see here. And so that's quite a marked reduction in cerebral blood flow with this head-up tilt protocol. Cerebral delivery of oxygen on the right side here has also decreased quite remarkably with that head-up tilt condition. And the arteriovenous oxygen difference, which is this measurement highlighted here, you can see that that's increasing, which is indicating an increase in oxygen extraction during this protocol. So you can clearly see that the increase in oxygen extraction is compensating for the reductions in cerebral blood flow and cerebral delivery of oxygen. This study the findings of this study have been recapitulated in additional studies in more recent times. This is from Nia Lewis's work with Phil Ainsley back in 2014, and they actually used a number of different protocols to induce reductions in cerebral blood flow. So on the top panels here we have global cerebral blood flow, and then the next panels down are the cerebral delivery of oxygen. You can see with hypocapnia and with indomethacin, you get reductions in both cerebral blood flow and reductions in cerebral delivery of oxygen, which then in turn increase oxygen extraction in order to compensate for that reduction in oxygen delivery and maintain cerebral metabolic rate of oxygen. So in terms of how that's related to the simulated hemorrhage condition of LBMP, so here we have a study that was conducted by Victoria K, my first PhD student in the lab from a few years ago. You can see here, this is middle cerebral artery velocity again. We now have a much smaller cohort of subjects. We have 7 high tolerant and 11 low tolerant subjects. This is their middle cerebral artery velocity response. There's actually no difference between these responses with this particular group. But when we assessed the cerebral tissue oxygenation, this is a measurement via near-infrared spectroscopy of the frontal lobe. You can see that in the high tolerant subjects in the closed circles here, there's relatively well-maintained oxygenation of the cerebral tissue. But in the low tolerant subjects, the cerebral oxygen saturation is progressively decreasing. At presyncope, there's a greater reduction in MCA velocity in the high tolerant subjects, and also greater reductions of SCO2 in the high tolerant subjects. So just to briefly review some of the assumptions that we make with near-infrared spectroscopy. Many of you are familiar with this technique, I'm quite sure. You can see the probe sitting on the forehead here. We have light penetrating through the various layers of tissue, including the cerebral tissue, and then light reflecting back into the probe. And then we can calculate or estimate concentrations of oxygenated and deoxygenated hemoglobin. This probe is measuring what we call a mixed sample volume, which includes about 75% venous blood, 20% arterial blood, 5% capillary blood. So as the blood is coming in through the arterial circulation, it's relatively well oxygenated, the hemoglobin's well oxygenated, the oxygen is offloaded into the tissues, and then we get a mixture of oxygenated and deoxygenated hemoglobin on the venous side of the circulation. And we can actually calculate cerebral oxygen saturation with the ratios of hemoglobin concentration and so oxygenated hemoglobin concentration and deoxygenated concentration. And we can calculate, we can estimate that with a decrease in oxygen saturation, that is approximating an increase in oxygen extraction, because we'll see increases in deoxy and decreases in oxyhemoglobin, mainly because the measurements predominantly from the venous side of the circulation. So in this study, you can see that oxygenated hemoglobin is progressively falling in the low tolerant subjects, and deoxygenated hemoglobin is progressively increasing to a greater magnitude in the low tolerant versus high tolerant subjects. At presyncope, there's no difference in oxygenated hemoglobin responses, but in the deoxyhemoglobin, there's greater increases in oxygen saturation. And so we infer that this is indicating a greater oxygen extraction in the low tolerant subjects compared to the high tolerant subjects during the LBMP stress. Okay, finally, the last part of my presentation this morning is a discussion about regional cerebral blood flow control. So again, the audience is very familiar with the anatomy of the brain, in that we can measure inflow to the anterior portion of the brain via intracranial vessels, the middle cerebral and anterior cerebral arteries, and then the inflow through the extracranial vasculature, including the internal carotid artery. On the posterior side of the circulation, intracranial vasculature can be assessed through the posterior artery and the basilar artery, and extracranial flow can be assessed through the vertebral arteries. And this, as I mentioned earlier, is important because the measurements through these vessels can reflect the inflow and perfusion to the brainstem, where we have autonomic and respiratory control centers. So again, from Victoria's study, I showed you already the middle cerebral artery velocity responses, both during LBMP and at presyncope. But then the posterior cerebral artery velocity responses were really interesting. So in the low tolerant subjects, in the open circles here, you can see that there's greater reductions in posterior cerebral artery velocity compared to high tolerant subjects, suggesting that perhaps this impairment in flow to the posterior portion of the brain is contributing to their low tolerance, and that they cannot launch sufficient compensatory responses to this hypovolemic stress. And then there's no difference, however, in the maximal response of presyncope between the high tolerant and low tolerant subjects. So in summary, I've shown you today that higher tolerance to simulated hemorrhage in humans is associated with increased oscillatory characteristics of arterial pressure and cerebral blood flow, a protection of posterior cerebral blood flow, a potential decrease in oxygen extraction, which may be due to a variety of reasons, but certainly we do need to examine other methods of measuring this, including the AVO2 difference measures, to confirm these findings with our near-infrared spectroscopy assessment. This reduction in oxygen extraction could be due to reduced metabolic demand of the tissues, perhaps greater efficiency of oxygen utilization, maybe differences in anxiety and stress. So there's a whole host of potential reasons why the oxygen extraction might be reduced in the high tolerance subjects. I think really importantly, moving into more clinical applications, current monitoring techniques for assessment of cerebral blood flow and oxygen responses in hemorrhage in patient populations are quite limited due to the difficulty in making these measurements. There's a lot of, particularly things like transcranial Doppler ultrasound and measurement of extracranial vessel flows. You need a lot of skill to be able to make those measurements, and that's not always feasible in the clinical setting. And just the need to treat the patient comes before making these types of measurements for research. So right now we're kind of limited in what we can do within the patient setting. Also, we need to continue to delineate the mechanisms associated with hemorrhage tolerance, and I think there's a big place for more animal models of actual hemorrhage and making cerebral vascular, cerebral blood flow and cerebral oxygen measurements, really to get a better understanding of what's happening with hemorrhage, particularly as we move toward the point of lethality. And then continue to investigate responses in human models of actual and simulated hemorrhage to really gain a greater understanding of what we're seeing with hemorrhagic injuries, and potentially developing therapies to protect the brain under these conditions. So finally, my acknowledgement slide. I'd like to thank all of my trainees here at the UNT Health Science Centre who have contributed enormously to the work that I presented today. My colleagues at the US Army Institute of Surgical Research, where I conducted my postdoc study. Bill Cook, who was also at the Army lab when I first joined them over 15 years ago now. He's now at Michigan Tech University. My colleagues at the Mayo Clinic, who provided the data for the hemorrhage versus LBMP study, and then all of the funding agencies, including the US Army, the American Heart Association, my institution for seed grants, and then the National Institutes of Health for training fellowships for a number of my trainees. So thank you very much.
Thank you very much, Karen. A very interesting and clear talk, a great way to kick off our seminar. So we will have time for one question, and there is one, so someone who used the chat feature, so Alexander Razumovsky. So we do know how important CO2 level is for maintaining autoregulation. So did you monitor CO2 during your experiments with LBNP?
Yes, we always measure CO2. Obviously, that's a necessity. If we ever measure brain blood flow, we need to measure CO2 as well. And there were no differences in the responses of CO2 between the high and low tolerance subjects.
Great, so don't be shy to send your questions using the chat feature. So Carolyn, I will let you the microphone.
Okay. Thank you so much, Pat. So I'd like to introduce our next speaker for the morning. So this is Garen Anderson is our speaker. Garen's actually a PhD student in my lab here at the University of North Texas Health Science Center. And Garen will be presenting more on the oscillatory blood flow. The title of his presentation is White Mountain Expedition 2019, Peaks and Valleys, Oscillatory Cerebral Blood Flow at High Altitude. Thanks, Garen.
Thank you. That's this. Everyone can see that okay? Okay, awesome. Well, first of all, I'm grateful to be able to present in this format, and also grateful to Dr. Rickards because she made my background easy. So for many of our studies, as Dr. Rickards has already described, we're focused on the cerebral blood flow during hemorrhage, and also developing therapies that protect the brain during this condition. So for those who may have just jumped into the seminar, we use lower body negative pressure to simulate blood loss conditions. And we do it in the stepwise protocol where we gradually decrease pressure. When we have subjects here in the chamber sealed in at the waist, this will pull blood volume from the upper body into the lower body. And we can measure that central hypovolemia with stroke volume measurements that we can see decrease with increasing levels of LBNP. And we do this often in subjects to the point of pre-syncope, which in our laboratory, again, is defined as a systolic arterial pressure of less than 80 millimeters of mercury, or experiencing visual disturbances such as nausea, or symptoms such as visual disturbances, nausea, and dizziness. And this varies subject to subject. It can happen at any point during LBNP. So for some, as an example, this may come early on, say, for example, at negative 30 millimeters of mercury of LBNP, and others further on into the protocol, maybe to negative 80 millimeters of mercury of LBNP. So one of the questions we have is what modifies someone's tolerance, or what contributes to their tolerance to this protocol. So as Dr. Rickards has already discussed a little bit, this is an example of two subjects going through this protocol. These are actually their arterial pressure tracings just before pre-syncope. And for the subject here on the top, you can see that their blood pressure is relatively stable up until they hit pre-syncope. Whereas compared to this subject on the bottom, who has a much more wave-like and oscillatory characteristic to their blood pressure. And interestingly, the subject on top is a low tolerance subject. The subject on bottom here is a high tolerance subject, enduring up to 30 minutes of LVMP. And again, if you were just to measure the mean arterial pressure response at this time point, these two subjects would look nearly identical. But there's more going on here. And this is also recapitulated in the middle cerebral artery velocity response. So again, the low tolerance subject having more of a flat, stable response, and then the high tolerance subject having this more oscillatory characteristic. So Dr. Rickards mentioned this briefly, but we need a way to measure the oscillatory characteristic of these waveforms. And the way we do that in our laboratory is using a fast Fourier transform. So any time domain signal that varies repeatedly over time can actually be broken apart into different sine waves at different frequencies. So that's what the fast Fourier transform essentially does for us. We can apply this transform to some signal in time, such as blood pressure, and then see what frequencies that signal is oscillating at, and how the amplitude of those signals. So for blood pressure, for example, you'd have an oscillatory frequency occurring at 1 hertz, which is due to heart rate. And you get some kind of peak indicating the amplitude of those waveforms. You'd also have another waveform within the respiratory range, which is a 0.15 to 0.4 hertz range, which is high frequency often. You'd have a low frequency component, which, as you can see here in the blue, from 0.07 to 0.15. In blood pressure, that's due to sympathetic activity. And then you'd also see peaks lower in the 0.04 to 0.07 hertz range, which is due to myogenic activity on blood pressure. And then so using this technique, we can quantify the amplitude of these oscillations in middle cerebral artery velocity and mean arterial pressure between high and low tolerance subjects over LBMP. And as LBMP increases, we see these increase in oscillations in high tolerance subjects compared to low tolerant. So this was just evidence to us that these oscillations may be conferring some protection to high tolerance subjects. So to further investigate that, one of my first studies, my first study in the lab, we used oscillatory LBMP as a means to induce these oscillations in arterial pressure and cerebral blood flow. So we used a oscillatory profile where we reduced chamber pressure down to -60 so that subjects became hypovolemic. And then we oscillated between -30 and -90 LBMP and did that at 5 seconds at each pressure repeatedly over 10 minutes. And then we examined a slightly slower frequency, same design, but at 0.05 hertz, and then compared that with a control condition. And then we measured heart rate, arterial pressure, cerebral blood velocity, and cerebral oxygenation, as well as end-tidal gases with gas capnography. And the main findings of this study, we saw a reduction in cerebral oxygenation, which we would expect with LBMP at the control condition. But interesting to us, we actually saw an attenuated reduction in oxygenation when we oscillate chamber pressure at both the 0.1 hertz profile and the 0.05 hertz profile. So the oscillations seem to be protecting oxygenation in the brain despite having this hypovolemic stress on board. And interesting enough too, this occurred when there were no differences between profiles and MCA velocity. So at least from MCA velocity, it didn't appear to be a flow, differences in flow that were mediating this protection and oxygenation. But for those who work with TCD, velocity isn't flow, it's only part of the equation. So one of the questions we had is flow protected, and we just miss it because we're only measuring velocity. And we don't have a cross-sectional area that we can use with TCD to actually calculate flow. And then another question we had coming out of this was, what happens in conditions of both reduced flow and hypoxia, which would be more similar to what we would see in a blood loss injury. So in August of last year, we actually had an opportunity to go on a high altitude expedition to White Mountain. This is a picture of Barcroft Laboratory up at White Mountain in California. It's at 3,800 meters. And this gave us a good chance to assess both of those questions that I had mentioned earlier. So our hypothesis on this expedition was that inducing oscillations in cerebral blood flow at the 0.1 Hertz profile that I showed earlier would be protective to cerebral blood flow and cerebral tissue oxygen saturation during the exposure to the combined stresses of simulated hemorrhage and sustained hypoxia. So for the study design, we had 8 healthy human subjects, aged 30 years old, and with a normal BMI. And it was a rapid ascent model. So we drove from Las Vegas to the Barcroft laboratory in about 4 hours. And then we waited until days 5, 6, and 7 to do testing on subjects, where we put them through these 2 profiles. So this control 0 Hertz condition again, and the 0.1 Hertz profile of LBMP. So similar to what we measured before, we had all of the same measurements on board, but we added ICA, or internal carotid artery blood flows with duplex Doppler ultrasound. This allows us to measure the diameter and the velocity of blood in that vessel, so we can get actual flow measurements. And then we also added arterial oxygen saturation and hemoglobin concentrations from a morning blood sample. So for our results, again, we saw this really robust protection in cerebral oxygenation, which is really interesting to us, even in the face of a hypoxic challenge. But also, again, there was no difference in the middle cerebral artery velocity response to these 2 profiles. And then when we took into account ICA blood flows, actually calculating flows, again, there's no difference between these 2 profiles. So we were still wondering, well, maybe it's an oxygen thing within the actual arterial system. So we had enough data that we could calculate the content of arterial oxygen. And just as a note, we used end-tidal O2s as a surrogate for the partial pressure of arterial O2. And then when we compared that between profiles, again, no difference. So the content of oxygen is the same between these profiles. But then we decided, well, let's just calculate the delivery of the oxygen, at least through the ICA with what we had, and see if there's any differences. And again, no differences with the delivery of oxygen between these 2 profiles. So in conclusion, we asked again, is it flow? And we're just missing it. And it doesn't seem to be that flow is protected by these hemodynamic oscillations at 1 Hertz. And as far as what happens in the conditions of both reduced flow and hypoxia, we still get a protection in SCO2 when we oscillate hemodynamics at 0.1 Hertz. So we're looking into this a lot further. This has still left a lot of questions for us, and it doesn't seem to be a flow-mediated mechanism or delivery mechanism that's protecting SCO2. We have some ideas that there may be some things going on at more of a microvascular level, but we have to start to dig into that more. So with that, I just want to thank everyone who has helped me thus far get all these projects done. Literally an army of people. So thank you, and I'll take any questions.
Thank you so much, Garen. That was a great presentation. I have a question from Craig Crandall. He's asking, is there any insight on the temporal resolution of the NIRS device? Is it possible that the protection during oscillations is actually the NIRS device not fully picking up the complete NIRS signal?
Yeah, that's a good question. I don't remember the exact sampling rate, but it's fairly quick. So the temporal resolution for the NIRS, it's taking samples a few times every second. I apologize, I don't remember the sampling rate, but it's a fairly quick response. So we do see it in time with these oscillations. So I think we're getting accurate measurements from, as far as timing wise, from that device.
And just as a follow-up, Garen, what is the time interval that you're measuring for each of the protocols?
Oh yeah, we took the last minute of LBMP for each subject, so it's averaged over the last minute.
Okay. Any other questions? Pat, do you have any questions coming to you separately?
Just out of curiosity, did you measure dynamic autoregulation, since you're using oscillatory LBNP? So you could like easily, especially if we consider one of previous Carolyn's slide where you said that the autoregulation was reduced during hemorrhage. So did you measure, or could be a possibility to measure cerebral autoregulation during those setup?
Yeah, yeah, you're right. We have that data. I haven't dug all the way into it yet, so I'd have to get back to you on that. But we need to further explore it. So there were some things in the first study that we saw, and I'm not recalling off the top of my head, but I haven't dug into that as much with the high altitude data yet.
Okay. There's also a question, John Smell just kind of had a follow-up question as well as Pat's with the transfer function analysis at 0.1 hertz. So as you say, that's something that you'll be exploring. And then Heather Edgell asks, have you calculated critical closing pressure from the MCA data?
No, we haven't done that yet. Good question. We haven't done it. So that's something we have to do too.
Okay. Well, thanks so much, Garen. I think we'll move on to the next presentation. We've got some great chat going on here, so please contribute to the discussion if you feel you'd like to. But we'll move on to the next talk for this morning. So the next presentation is from Joe Watso, and Joe is a postdoctoral fellow with Craig Crandall at the Institute for Exercise and Environmental Medicine here in Dallas, Texas. The presentation of Joe's, so the title of Joe's presentation is The Effect of Low-Dose Ketamine Administration on Cerebrovascular Function During Simulated Hemorrhage in Humans. Thanks, Joe.
All right. So just want to thank you for the opportunity to speak here today. So the title of my talk is The Effect of Low-Dose Ketamine Administration on Cerebrovascular Function During Simulated Hemorrhage in Humans. So as previous speakers alluded to, we know that hemorrhage is a leading cause of preventable death in the battlefield. And on the battlefield, there are currently 4 pain treatment options that are recommended by the US Army. They include morphine, fentanyl, sufentanil, and ketamine. So you may be familiar with ketamine as an anesthetic, which is true at high doses. However, ketamine in low doses does provide analgesia. And you can see that the 20 milligram dose of ketamine recommended by the US Army fits right within that analgesic range. An interesting note about ketamine is that in the guidelines, they recommend that it could be used for those who have moderate to severe pain, or those who have or are at significant risk for hemorrhagic shock or respiratory distress. Whereas the opioids, the 3 other medications, entail a risk for cardiorespiratory depression. So while this information is helpful, a lot of this data is actually based on data obtained in animals. There is one study to date that administered low-dose ketamine to healthy young adults, and you can appreciate the large and significant increases in heart rate on the left panel, mean blood pressure in the middle panel, and mean middle cerebral artery velocity on the right panel. And you can see that the mean values are sustained to be higher for 15 to 20 minutes, depending on the variable you're interested in. So despite this occurring back in 1990, there's actually a review that was just put in print this May, including after a short section on ketamine, that more research is needed to inform our clinical thinking on this important drug for ketamine in reference to ketamine in the setting of hemorrhage. So this led us to test the questions related to, does ketamine affect tolerance to a hemorrhagic insult? And does it affect the associated cerebral hyperperfusion that occurs? Therefore, the purpose of the study was to test the hypothesis that ketamine does not impair hemorrhagic tolerance, nor does it worsen the cerebral hyperperfusion that occurs during a hemorrhagic insult. To answer these questions, we employed lower body negative pressure using a stepwise protocol as previously described very nicely by our two speakers. For this protocol, we started an LBNP of 40 and incremented it by 10 every 3 minutes to a maximum of 100 until an individual displayed signs of presyncope. And individuals came into the laboratory on 2 separate occasions in random crossover fashion and received placebo or ketamine while they were blind to experimental condition. For the data set I'll be presenting today, they come from 16 young adults with a BMI below 32, body mass values above 65 kilograms. So first, we're looking at survival. So this is survival in terms of presyncope on the y-axis. And you can see on the x-axis, we have cumulative stress index. And the cumulative stress index takes into account the pressure that the individual was experiencing and the time at which they experienced that pressure. So here you can see that compared to placebo in the gray bar, ketamine in the green bar was not different between cumulative stress index throughout this presyncopal limited LBNP test. Similarly, if you were to plot out ketamine minus placebo to determine if they fared better or lasted longer during the test after ketamine administration or not, you can see again that there is no difference across all subjects. However, you do see a little bit of variability with those in the gray bars or going leftward, indicating that they fared better or lasted longer with the placebo administration, whereas those going rightward or in the green bars representing that they did better with ketamine. So for the next several slides, I'd like to orient you to the layout for specific time points. So first we have the pre-time point, which represents a 5-minute baseline that occurred before drug administration or LBNP. Next, there's a 1-minute period following administration of placebo or ketamine. We analyzed the final minute of the LBNP stage 40, as well as stage 50. And then regardless of when an individual had their test terminated due to signs of presyncope, we analyzed the final 20 seconds to gain additional insight as to the cardiovascular and cerebrovascular variables that were displayed at that time. So first, we're looking at heart rate on the y-axis, and you can see across time, there's a significant main effect. So there was higher heart rates obtained at the end of LBNP compared to pre-LBNP as expected. And you can also see that in the green bars, which represent the ketamine trial, compared to the gray bars, which represent the placebo trial, there's a significant main effect of condition at LBNP stage 40, indicating that ketamine raised heart rate relative to the placebo trials. For mean blood pressure obtained via photoplethysmography, we can also see that there's a significant main effect of time as expected, with participants exhibiting the lowest blood pressures at the end of LBNP. It's also important to note that these pressures obtained at the end of LBNP were not different between trials, indicating that these tests were terminated at a similar point in time relative to the individual's hypotensive response. Next, we looked at the respiratory responses during the LBNP challenge. And here we have respiratory rate on the y-axis, and this was obtained via nasal capnography. And you can see that there is no effect of either time or condition for this variable. For end-tidal CO2, again, as expected, this was reduced throughout the LBNP test. However, at no time points was it different between conditions. Interestingly, we saw that mean middle cerebral artery velocity obtained from the right middle cerebral artery was indeed lower at the end of LBNP compared to before the LBNP challenge. And again, at the LBNP stage 40, we observed higher MCA velocity values during ketamine compared to the placebo trials. However, when we take into account the modest and non-significant increases in blood pressure that occurred at the same time points to calculate the cerebrovascular conductance index, this difference was abolished. Therefore, it wasn't surprising to us when we determined that cerebral oxygen saturation, though it was decreased throughout the LBNP challenge, it was not different between conditions. Similarly, oxygenated hemoglobin values were not different between conditions, although as expected, they did decrease at the end of LBNP compared to pre-drug administration or LBNP. So from these data, there are three main take-homes. The first was that ketamine administration in young adults did not impair hemorrhagic tolerance. It led to an increase in MCA velocity during moderate hypovolemia. However, the CVIC data suggested that this effect might be mediated in part by the non-significant increases in blood pressure. And finally, it didn't seem to affect indices of cerebral oxygen saturation. So circling back to our hypotheses, we would conclude that ketamine administration does not impair hemorrhagic tolerance and does not worsen cerebral hyperperfusion that occurs concomitantly. So the clinical take-home would be that our preliminary experimental data would suggest that a 20 milligram administration of ketamine would not be detrimental to cardiovascular or cerebrovascular function in a hemorrhaging soldier on the battlefield. So with that, I'd like to thank the laboratory team who helped collect and analyze and interpret these data. And I'm happy to answer any questions that the audience might have. Thank you.
Thank you so much, Joe. That was a really intriguing presentation with very unique data that you're able to collect there with Dr. Crandall's group. So do we have any questions in the chat from the audience? I'll just ask a question, Joe, while people are tapping away. So you addressed the responses to ketamine, but you mentioned there were other studies with other analgesics. Do you have any insight into if there's differences between the different analgesics tested?
To date, so far, we're testing 3 drugs that were originally determined to be helpful in that setting. So ketamine, fentanyl, and morphine. We're currently we have trials ongoing to test the effects of fentanyl and morphine separately. The morphine data is probably too preliminary to make any determinations, but I will say in the 20 or so individuals we've tested for fentanyl, it doesn't seem that there appears to be any detriment in terms of hemorrhagic tolerance. But of course, that's ongoing, so we'll see what happens as we continue to collect more data.
And what's the timing from administration of the drug to testing, and what's kind of the half-life of these drugs? Do you have any concerns about maybe they're being washed out by the time you get to the end of the protocols?
Yeah, that's a great point. Specific to ketamine, most of the effects seem to peak around 5 to 10 minutes, but they do last 15 to 20 minutes depending on the individual or the dosage. So here, being that the mean tolerance time from drug administration was around 11 or 12 minutes, we think that a large majority of these individuals probably still have a lot of effects of the drug during the both LBNP challenge as well as when they obtained pre-syncope. But of course, there could be a few individuals who might have been later. But these data across don't suggest that there's any potential interaction there. But that's certainly a consideration. Sure.
Thank you. Any additional questions from the group? Okay, I don't see anything coming through, Joe. So thanks so much for your presentation this morning. We appreciate your participation today. So let's move on to the next presentation. So our next talk is from Milena Samora. Milena is a PhD student at the University of Brasilia with Lauro Viana. The presentation today was actually conducted with James Fisher at the University of Auckland in New Zealand. The title of Milena's presentation is Neurovascular Coupling is not influenced by lower body negative pressure in humans.
Thank you, Caroline. First of all, I hope that all of you are safe and well. And I would like to thank the organization for inviting me to present today. I'm so glad to do this. As you introduced me, Caroline, I'm Milena Samora, and the title of my presentation today is Neurovascular Coupling is not influenced by lower body negative pressure in humans. Neurovascular coupling is the unique relation between brain activity and cerebral blood flow. Several mechanisms are being postulated to explain this local vasodilation due to brain activity. For example, we have some metabolic byproducts of brain activity, such as adenosine, lactate, CO2, and also the release of nitric oxide, which is an important vasodilator. Also important to consider is the role of autonomic nervous system in regulation of blood flow to the brain. Previous studies in animals and humans demonstrated a decrease in cerebral blood flow when sympathetic activity is stimulated. In addition, in this elegant study in awake animals with microinjections of alpha-adrenergic agonists, they demonstrated a robust increase in cortical astrocyte activity. And the astrocytes are an important component of neural network and neurovascular coupling. So the question that rises here is whether sympathetic nervous system plays a role in the regulation of neurovascular coupling also in humans. And this is important because an attenuated neurovascular coupling has been reported in some disease, such as hypertension, but also in healthy aging. And interesting, both of these conditions are associated with higher sympathetic activity at rest and also increased risk of cognitive decline and dementia. Well, a relationship between impaired neurovascular coupling and cognitive decline function have been already reported, but if higher sympathetic activity influence neurovascular coupling is unknown. So based on this, our aim was to test the hypothesis that reflex-mediated sympathetic activation via lower body negative pressure, LBNP, attenuated neurovascular coupling in healthy humans. To test this, we recruited 11 subjects. All of them were healthy and young. We have 3 women, and all the tests were done at Auckland City Hospital in New Zealand. So this was our setup. So we measure beat-to-beat blood pressure, heart rate, respiratory rate, and tidal CO2, and we used this LBNP chamber to increase sympathetic activity. And here we have our cerebral blood flow measurements. So using a transcranial Doppler ultrasound, we measure the velocity in the posterior cerebral artery. I will call this PCA on the right side. And on the left side, we measure the velocity in the middle cerebral artery, MCA. And just because the transcranial Doppler ultrasound only measures velocity, we decided to further describe neurovascular coupling, and then we included a duplex ultrasound to measure the velocity diameter and then calculate blood flow in the vertebral artery on the same side of the PCA. So the subjects rested for 10 minutes, and then they did 3 different trials. We used a mild to moderate intensity of lower body negative pressure. So here we have no negative pressure is our control. Here we have -20 and -40 millimeters of mercury in a randomized order. The first 5 minutes was just the negative pressure, and then the last 5 minutes, the subjects performed the neurovascular coupling test. We used a visual stimulation protocol proposed by Eslid in 1937, and it consisted by 5 cycles of 30 seconds with eyes closed and 30 seconds with eyes open reading some material. During the eyes open phase, we can quantify the neurovascular coupling, so we can measure the coupling between brain activity and the increase in cerebral blood flow to the visual cortex. In this table, we are just showing that our protocol was effective to increase sympathetic activity. So as you can appreciate here, we have a decrease in systolic blood pressure during LBNP. Also, we have a decrease in stroke volume and cardiac output. And then we have a reflex increase in heart rate and total peripheral resistance. We also used heart rate variability. So as you can see here, we have a decrease in parasympathetic activity to the heart and an increase in sympathetic activity to the heart. We also observed a decrease in the tidal CO2 during LBNP, but I'm going to talk about this later. So this is our main finding. So as you can see here, we have time before and during visual stimulation. And here we have the velocity in the PCA. So as expected, under control condition, we have an increase around 18% in the blood velocity during visual stimulation. And this is neurovascular coupling response. And the response during LBNP was not different between -20, -40 or control. So LBNP didn't affect the neurovascular coupling response in PCA. The same, so here we have time before and during visual stimulation, but now we have blood flow in vertebral artery. So under control condition, we have an increase around 10% during visual stimulation, and this is neurovascular coupling response in VA. And even though we have an attenuated response before visual stimulation, as you can see here in the gray and the black lines, the magnitude of change wasn't affected by LBNP as well. As I said before, we have a decrease in the untitled CO2, and as we know that CO2 is an important regulator of cerebral blood flow, and then we decided to run a control study. So we have a subset of 8 participants who come back to the lab, rested for 10 minutes, and then did 2 different trials in a randomized order without LBNP. So the first 5 minutes was just to match the fall in CO2 using a hyperventilation protocol. And then the last 5 minutes, the subjects performed the neurovascular coupling test again. As you can see here, we matched the fall in CO2 comparing the hyperventilation protocol and the higher level of LBNP. And the neurovascular coupling response in PCA and in VA was the same comparing hyperventilation, eupnea, and LBNP. So our results can be summarized as that the increase in PCA to visual stimulation, I mean the neurovascular coupling response, was unaffected by LBNP. The visual stimulation evoked a moderate increase in VA flow, and this was also unaffected by LBNP. And although LBNP induced a mild hypocapnia, this degree of hypocapnia failed to modify LBNP. So our conclusion was that the neurovascular coupling is not influenced by reflex-mediated sympathetic activation via lower body negative pressure or mild hypocapnia in humans. Well, since we studied only healthy and young subjects, our findings cannot be extrapolated to older or diseased population. However, as neurovascular coupling is used as an index of cerebral vascular function, now we have another question to address. So, for example, if we would be able to inhibit the sympathetic activity in hypertension patients or elderly population, we will restore the neurovascular coupling response. So maybe this could be our next step. I would like to thank my supervisor here in Brazil, Dr. Lauro Viana, also the University of Auckland for all support, my supervisor there, Dr. James Fisher, all my team here in Brazil, the collaborators for this study, and all my fundings for your attention. Thank you.
Thank you so much, Milena. That was a great presentation, and I see you have that paper published, so that's excellent as well.
Yes.
We have a couple of questions in the chat here. One from Jay Carr. He asks, do you think there could be escape of vasomotor control from sympathetic nervous activity after 5 to 7 minutes, which might reduce the influence of sympathetic nervous activity during NVC at each stage?
Yes. Yeah, this could happen, maybe.
Okay, just as a follow-up to that, did you have any measurements of sympathetic activity in these subjects?
No, sympathetic activity, no.
Okay, I wonder about the variability of sympathetic activity between subjects. So you're using your specified LBNP stages, which might induce differences in sympathetic activity.
Yeah, we just estimate this using heart rate variability.
Another question from Mike Timko. He says, nice touch by matching the CO2 during a control trial and assessing neurovascular coupling, but what about the reduction in cardiac output associated with LBNP? So how would that influence your response?
Yeah, but we didn't see any differences in mean blood pressure, so we care about this. And the control study was just because we observed this fall in CO2, and yeah.
Okay. Wesley Lefferts has a question. Hi, Milena, very nice talk. Mild LBNP has been shown to stiffen the large elastic arteries, potentially altering pulsatile transmission into the cerebrovasculature. Did you and your team look at anything with changes in the pulsatility index with NVC during LBNP?
Yes, we used pulsatility and resistance index in MCA and PCA, but we found that this were higher during LBMP, but was not different during the neurovascular coupling test. We have this data on the paper.
Okay. There you go, Wes. Have to read the paper.
Oh, thank you.
Okay. Well, that's great. We have some great questions in the chat there. So thanks so much, Milena. Appreciate you.
Thank you so much.
Today.
Thank you.
Okay, so let's move on to our final abstract talk for this morning. So this is also from my lab here at the North Texas Health Science Center from AJ Rosenberg, who's a postdoctoral fellow. AJ's presentation is also from our White Mountain expedition from 2019, the impact of sustained hypoxia on cerebral blood flow responses and tolerance to simulated hemorrhage. Thanks, AJ.
Well, thank you very much, Caroline, for that wonderful introduction. And thank you very much for this opportunity to present some of our White Mountain research expedition with you all today. This is very exciting for us to be able to do this. So I'd like to begin by stating that hemorrhage, or massive blood loss, is one of the leading causes of potential survival or death, both in the military and civilian settings. In a high altitude environment, traumatic blood loss can occur from battlefield injuries, motor vehicle accidents such as snowmobiling, air accidents with helicopters or airplane crashes, or major falls with climbing, skiing, or snowboarding, and of course, avalanche accidents. This combination of reduction in blood flow due to blood loss and the decreased arterial oxygen content due to the hypobaric environment will ultimately attenuate oxygen delivery to the vital organs and tissues, and in particular to the brain, which is one of the primary focuses of our laboratory. In a very nice review conducted by Dr. Phil Ainsley, he combined 8 different studies that assessed cerebral blood flow response and arterial blood gases to prolonged exposures to high altitude, ranging from roughly 3,000 meters to 5,000 meters. And as you can see depicted here, they calculated the arterial oxygen content. And within the first 24 to 72 hours, we see this robust reduction of almost 20% in arterial oxygen content. Consequently, we have a compensatory increase in the cerebral blood flow response over that same time period to compensate for that reduction in arterial oxygen content, which ultimately leads to a preservation of cerebral oxygen delivery as depicted here on the graph to the far right. However, in humans, the effect of sustained hypoxia on tolerance to hemorrhage and the cerebral vascular responses to this stress are unknown. Therefore, based on the known compensatory increases in cerebral blood flow that occur with exposure to hypoxia, we hypothesize that tolerance to a simulated hemorrhage at high altitude would be similar compared to low altitude due to increased cerebral blood flow and oxygen delivery and the subsequent preservation of cerebral tissue oxygenation. So as Dr. Rickards, as well as Garen had, we use a model of simulated hemorrhage via lower body negative pressure chamber as depicted here over on the left-hand side. This is our pre-syncable LBMP protocol that was employed throughout this study. And it may look familiar as Garen presented on the first 15 minutes, where we have a 5-minute baseline followed by a rapid reduction to negative 60 millimeters of mercury for 10 minutes. If subjects went to this 10-minute mark, we continue to reduce the pressure in the chamber by 10 millimeters of mercury for every 5 minutes until pre-syncope was reached, which is defined as a systolic arterial pressure of less than 80 millimeters of mercury and or the onset of pre-syncopal symptoms. And what's important to note, as Garen mentioned, is that pre-syncope can occur at any time point throughout the protocol. So for a model of sustained hypoxia, Dr. Rickards, myself, and Garen Anderson packed up our entire laboratory in 4 Pelican cases. And I'm not gonna lie, we actually had to put some of our equipment in our carry-on as well and get that up to Calgary for our low altitude testing. So we performed our pre-syncopal LBMP protocol during days 1 and 2 of low altitude exposure. Following our low altitude experiments, we traveled to White Mountain, California, where we spent 12 days at the Barcraft Research Laboratory at 3,800 meters, as depicted here in this amazing picture at 3,800 meters, where we assessed our high altitude presyncopal protocols between days 5, 6, and 7. The measurements that were assessed in the study consisted of cerebral blood velocity via transcranial Doppler, internal carotid artery blood flow of the right ICA via duplex Doppler ultrasound. We assessed arterial pressure via finger photoplethysmography, cerebral oxygenation of the frontal cortex via near-infrared spectroscopy, end-tidal O2 and CO2 via gas capnography through an oral nasal cannula, and arterial oxygen saturation via finger pulse oximetry. It is also important to note that we assessed hemoglobin concentrations each morning of our experimental trials, which allowed us to calculate the arterial oxygen content. And I'd like to point out that we used end-tidal O2 as a surrogate for our PO2 in the arterial oxygen content equation. Upon calculating the arterial oxygen content, we were then able to use our ICA blood flow and multiply this by the arterial oxygen content to give us an index of cerebral oxygen delivery. So in support of our hypothesis, we see that there is no difference in simulated hemorrhage and tolerance between the low and high altitude. And tolerance was assessed in time to presyncope in seconds in 8 subjects, as Garen described earlier. I would like to take a second or two just to orient everyone to this figure here on the right, because all the following figures and slides will be depicted in this format, where we have the variable of interest on the y-axis, the number of subjects here in the upper left-hand corner. We have the low altitude is represented with the closed circles, and the high altitude is represented with the open circles. We have the overall main effects here on the lower left-hand corner, and then we have our post hoc comparison p-values here with the asterisk versus baseline and the cross versus the altitude. So I'd like to begin by pointing out here that with stroke volume, our index of central hypovolemia, at baseline, there is a difference between high and low altitude, with a reduction in stroke volume index at high altitude. However, with LBMP, both at low and high altitude, we see a reduction in stroke volume with no difference in altitude, demonstrating that we see this nice central hypovolemic stimulus with both conditions. In regards to cerebral blood flow, as indexed via the mean middle cerebral artery velocity, we can see at baseline there's no differences between subjects at high and low altitude. And both with LBMP respond similarly with a reduction of roughly about 30% at presyncope. Interestingly, and as expected, we see an increase in ICA blood flow at baseline, where we see this compensatory increase in the high altitude condition as compared to the low altitude condition. And again, with LBMP, we see a similar reduction between both the low and high altitude conditions with no difference. Consequently, when we calculated our arterial oxygen content, we do not see a difference at baseline or at presyncope between the high and low altitude conditions. Therefore, because we have an increase in ICA blood flow, but no difference in arterial oxygen content, we have a difference or an increase in cerebral oxygen delivery, both at baseline as well as presyncope with LBMP. Interestingly, and therefore, this increase in cerebral oxygen delivery leads to the preservation of cerebral oxygenation as depicted here in the figure on the right-hand side, where we have no differences at baseline and no differences at presyncope with LBMP. So I'd like to summarize that hypoxia with ascent to 3,800 meters does not affect tolerance to simulated hemorrhage in young adults. This compensatory increase in cerebral blood flow and oxygen delivery results in the preservation of cerebral tissue oxygenation in response to this sustained hypoxia. One of the limitations, and what is still unknown, is the acute effects hypoxia. So as I depicted earlier on in one of the background slides, we see this reduction in arterial oxygen content within the first 24 to 72 hours, which we did not able to capture because we tested and assessed our high altitude stimulus during days 5, 6, and 7. As well as it may be interesting to see the minute to hour effects of this acute hypoxia, which may possibly affect tolerance to the stimulus. So I'd like to make my acknowledgments, and in particular to Dr. Caroline Rickards for being the most wonderful mentor anyone could ever ask for as a postdoc, as well as thank Garen and her for putting up with me during the first few days of our exposure to high altitude, because I was not feeling very well, and the combination of lack of caffeine was not fun. You don't really want to be around me. So they were a great support team, and it was a wonderful pleasure to be with them. And I'd also like to personally thank Dr. Day as well as Dr. Wilson for organizing this expedition and allowing us to be a part of it. And of course, our funding sources, and in particular, the entire team that we just had a wonderful time together up at White Mountain for those 12 days, as well as the also 7 days that we spent together in Calgary. So we got to know each other pretty well. So at this point, I'd like to take any questions and thank everyone for your attention.
Thanks so much, AJ. I've got a couple of questions for you on the chat here. One from Mike Timko. How closely did end-tidal O2 reflect arterial oxygen partial pressure in Calgary and at high altitude?
So that is a very good question. We still haven't run the actual statistics on that yet. I will be doing that. But just from an anecdotal perspective and looking at the values earlier this morning, they were fairly close. But unfortunately, I cannot make any definitive statement in terms until I actually run the statistics if there were a difference or not between those. So that's a very good question.
Great. Craig Crandall states, nice presentation. How long were you at altitude, and did you repeat the trials after they were acclimated to altitude?
So we were at altitude for a total of 12 days. The first trial, the first subject went through on day 5, and we finished all of our testing on day 7. So there was a 3-day period that we did testing. So unfortunately, we did not retest or assess the acclimatization, but I think that's one of the limitations that it was just very tough to ask our subjects to do an LB&P portion with all the other tests that were going on during those first few days to really assess that progression of acclimatization. But I think that's ultimately the next question, seeing if we did assess individuals during those first 24 to 72 hours, would we see a difference between our responses and tolerance, and whether or not acclimatization, which occurred between that 5, 6, and 7, caused no difference in tolerance.
Great. I have a question from Kathleen Miller. Nice talk, AJ. Since you saw higher ICA flow at high altitude at baseline, but no change in MCAV, do you think the MCA is vasodilating? Or do you have other evidence of increases in anterior circulation flow?
Yes, that's a very good question. It is possible that we are seeing that. Unfortunately, we don't have any measurements to accurately assess the diameter of the middle cerebral artery. It'd be wonderful if we were able to bring an MRI up to 3,800 meters, but it was tough enough just getting an LB&P chamber all the way from Calgary to California, which was a big to-do. So thank you, Dr. Wilson, for driving that for us. But kind of to answer it slightly, as we did with the ICA measurements, we do have diameter measurements. And with that, we did not see any changes between low and high altitude with any of our ICA measurements. The changes in cerebral or the ICA blood flow responses were driven by changes in the velocity. So based on that, I could speculate that there may not be a difference. However, until we actually measure the MCA diameter to really answer that question.
Okay. Well, thanks so much, AJ. So we don't have any more questions on the chat for you. And we're right at time. So I really appreciate everyone's presentations this morning or afternoon, wherever you may be in the world right now. Just to highlight, the next presentations will be next week. AJ, can you just
yep.
your screen for a
there
second?
we go.
I just want to share the next one here. All right. So this is next Thursday, June 9th. The presentations will be with Pat Prasad as the keynote speaker, and focusing on the role of exercise on cerebral blood flow regulation. So Pat, do you have any comments, questions here at the end?
No, well, just thank you very much for your for the attendance, and it was really a nice first seminar. So I'm pretty excited to see the upcoming ones. So again, thank you.
We can stay online for a few minutes if anyone would like to ask additional questions, but also you're free to leave if you have other things to do. But we really appreciate your attendance, and again, thank you so much to the presenters this morning for your excellent talks. I think they were really insightful and generating lots of great questions. So thank you, everyone.